This lecture will examine nursing situations for clients with heart failure, or sometimes referred to as congestive heart failure. If we look at what heart failure is, it's where the myocardium cannot maintain cardiac output to meet the body's metabolic demands. This leads to a decreased cardiac output, decreased tissue perfusion, and when we look at different types of heart failure, it could be systolic failure or diastolic failure. There are probably about 5 million Americans that have congestive heart failure, and it's the most common diagnosis in hospitalized patients over the age of 65. There are many, many different causes of heart failure. Systolic failure, the signs and symptoms of this are the patient has decreased cardiac output, they're very weak and fatigued, have very decreased exercise tolerance, and as you can see, many causes: coronary artery disease, hypertension, metabolic disorders, myocarditis, cardiomyopathy, valve problems, ischemia and infarcts within the heart, inflammation of the heart, alcohol and caffeine can all cause systolic failure. So this is where the failures fail to contract adequately to eject a significant blood volume into the arterial system, so that patient has very poor cardiac output with this. Diastolic failure results when the heart can't completely relax in diastole, so it disrupts normal filling pressures within the heart, and that leads to increased ventricular pressures and ventricular congestion. Signs and symptoms of diastolic failure include shortness of breath, tachypnea, sorry about the spelling there, crackles, neck vein distension, liver enlargement, and nausea. Causes could include coronary artery disease, hypertrophy of the heart, pericarditis or myocarditis, which are inflammation of the heart, cardiomyopathy, stenosis and fibrosis, and ventricular remodeling, and different collagen diseases can lead to that. And just refer to your readings in your textbook for further details on those areas. Vocabulary that you need to know for this particular lecture include these that are listed here. So cardiac output is the amount of blood pumped from the ventricles in a minute. Cardiac reserve is the ability of the heart to increase cardiac output to meet metabolic demands. Heart rate affects cardiac output by controlling the number of ventricular contractions per minute. Stroke volume is the volume of blood ejected with each heartbeat, and everything that plays into that would include preload, afterload, and myocardial contractility. Preload is the volume of blood in the ventricle at the end, diastole just prior to contraction, and afterload is the force needed to eject blood into the circulation. Contractility is the ability of the cardiac muscles to shorten during systole, and ejection fraction, which is a term you'll see on your patients that are back in a cardiac unit, is the percentage of blood in the ventricle that's ejected during systole. So usual normals for ejection fraction is around 60% or so. This will vary slightly depending on the source that you use. Some common diagnostic tests for our patients in cardiac or congestive heart failure include the chest x-ray, B-type natriuretic peptides. These are actually peptides found in the heart ventricles, and they increase in the blood levels when the ventricular filling pressures are high. So it kind of is a helpful diagnostic test to look at distinguishing between heart versus lung problems in patients. And it's just done as a simple lab draw. And it also, one thing that this particular BNP does is it decreases the levels of angiotensin II and aldosterone, so it can cause some arterial and venous vasodilation. EKGs are useful in identifying cardiac pathology and arrhythmias. Echocardiograms is very useful in heart failure because it can look at left ventricular ejection fraction. And remember, those patients that have an EF below 40% shows they have significant left ventricular dysfunction. Normal is about 60% or so. Cardiac caths can give valuable information about the hemodynamic functioning of the heart, and you learned that in a past lecture. And then remember the appropriateness and importance of looking at all the different lab values for those patients. LFT stands for liver function tests. And for those patients in heart failure, you're going to see why it's important to also look at liver studies. This is a chest x-ray for a patient that actually has heart failure. As you can see there, the heart is very, very enlarged. It almost takes up the entire chest cavity. You can't even see lung function because of the way the heart is so enlarged. And if I had to guess, this patient, it would probably be someone that would be a good candidate for perhaps a heart transplant. The device that you see on the chest x-ray with the wires is a pacemaker up on the right-hand side of your screen. Of course, that would be on the patient's actual left side of the patient since they're standing opposite. The classic assessment findings in heart failure that are seen are dyspnea on exertion. The patient has orthopnea, which remember is trouble breathing when they're lying flat. They may have nocturnal dyspnea, trouble breathing at night, a dry, hacky, persistent cough, unexplained fatigue, that type of a thing. As that patient's symptoms progress, then you'll start to see crackles in the lungs. You may hear an S3 or an S4 heart sound on the patient. They'll have peripheral edema, weight gain, jugular vein distension, hepatic engorgement over the liver, ascites, which is another symptom of hepatic engorgement, and the dyspnea will keep getting worse. Other signs and symptoms of failure are alternating periods of apnea with hyperpnea, angina, tachypnea, decreased systolic blood pressure with increased diastolic blood pressure, nausea, vomiting, bloating, epigastric pain, altered level of consciousness, confusion, and restlessness due to poor cardiac output to the brain, decreased activity tolerance. The patient may have postural dizziness due to poor cardiac output, and pitting edema, and cool extremities and anxiety. So patients can have right failure or left failure or both. And most typically we usually see that the patient has both. But in the early signs and symptoms, or I should say in the early stages, you may see a patient that starts with left, progresses to right, or vice versa, that type of a thing. But a patient that has right heart failure, you're going to see a backup from the right ventricle because that ventricle's not working. So if you think about, most often heart failure occurs first in the left because of that heavy workload and increased oxygen demand, and then right heart failure will develop with a backup to the venous system and those types of things. So when the right side of the heart fails, it leads to the symptoms that you see here: pretibial edema, neck vein distension or jugular vein distension, JVD, hepatomegaly, ascites, and gastric distension. And the patient, because of the hepatomegaly, which is a liver enlargement, they have a lot of venous congestion in that liver. It leads to increased size, which can then lead to ascites due to decreased production of albumin by the liver, and it causes all the edema and gastric distress and anorexia that the patient has. For those patients that have right-sided heart failure, you'll start to, this is going to focus on left-sided heart failure. For those patients that have left-sided heart failure, the blood backs up from the left side of the heart, so you start to see all the lung problems. So with patients with left-sided heart failure, you will see shortness of breath, orthopnea, cough, crackles, S3 heart tones on those patients, and that's because you hear the S3 because of a rapidly filling ventricle that's already partially filled. This picture depicts what neck vein distension looks like in clients. So you can see the picture to the right. Remember, when the head of the bed is elevated about 35 degrees, neck vein distension should go away. A lot of patients will have it when they're lying flat in bed, but as you elevate that bed up to about 35 degrees, you should see it go away. But you can see in this particular patient, it's still quite apparent. Hepatomegaly, there's a picture of an enlarged liver due to hepatomegaly on the right side of the screen. And you can see that that leads to ascites, which is a picture in the next particular slide. So the patient on the right there has quite a distended abdomen with ascites and dependent edema. And this particular patient would probably require paracentesis to remove the excessive fluid from the abdomen that has accumulated due to the liver function that has decreased. So see your book. The page is listed in the speaker notes for paracentesis and difficulties with ascites. This is just a picture of a cat that has ascites. So not only can all of these signs and symptoms happen to humans, but they can also happen to animals. And as we said, one particular symptom we sometimes see on our patients in left-sided heart failure are crackles. And this is another type of crackles that sometimes you'll find on your patients that are in a hospital setting in those wonderful hospital gowns. Who's at risk to develop heart failure? Patients that have any of the problems listed there: coronary artery disease, atherosclerosis, congenital heart disease, valve problems, hypertension, post-MI patients or severe ischemic patients with cardiac tissue damage, pulmonary hypertension, cardiomyopathies, and all sorts of different things. So interestingly enough, about 30% of clients that do have heart failure also will have undiagnosed obstructive sleep apnea due to vasoconstriction of the pulmonary vascular bed due to hypoxia. This would list your priority calls for nursing, and remember, you always want to follow that up with a related to, and remember, your related to cannot be your diagnosis or your medical diagnosis for the patient, but gas exchange, tissue perfusion, fluid volume excess, activity problems, hopelessness, and decreased knowledge levels would all be calls for nursing for your patients in CHF. Medications typically are used for these patients. They may be on multiple classes of medications in order to treat it. The first line defense is usually diuretics, such as Lasix and those others that are listed there for you. If diuretics alone do not treat the symptoms, then the patient may have ACE inhibitors or inotropic agents added into their medication regime. So remember, ACE inhibitors decrease the workload of the heart by decreasing resistance and decreasing secretion of aldosterone. Remember your aldosterone angiotensin system from your patho class. When that's out of whack, it causes the patient to retain sodium in water. So ACE inhibitors will help that patient excrete some of that sodium in water that they have on board that's too much. Inotropic agents, one of the best ones or most common ones used in this category is digoxin, which increases the force and the contraction of the heart. Be real careful to look for signs of toxicity with digoxin. And another one used commonly is dobutamine. So this is an IV medication that would be used to help with symptoms of congestive heart failure. And listed on your speaker notes are some pages to refer to that look at different medications used in CHF patients. Some other medications used are vasodilators, beta blockers, IV Natracor, which is a dilator diuretic effect. It's indicated for the acutely decompensated heart failure. And with this particular Natracor, it's a human B-type natriuretic peptide, BNP. And with this one, it helps to bind to vascular smooth muscle and endothelial cells, which leads to dilation of the arteries and veins and suppresses different neurohormones. So it's a very helpful drug to be used with your patients in extreme CHF. And also patients may need to also be on antidysrhythmics. Surgical treatments for patients with heart failure. If medication alone was not treating that patient's symptoms, then they may need to be on a heart transplant list. The survival rate is listed here for you. Depending on your source, that will change just slightly. And nursing care is listed in your book for a patient that's had transplant done. Remember, they'll be on anti-rejection meds or immunosuppressants such as cyclosporin for life. And it would be important to look for signs and symptoms of rejection, which can actually take place years after the transplant. It's not necessarily something that happens immediately. So fatigue and weakness, fevers, tachycardias, dysrhythmias, edema, sudden weight gain, hypotension, flu-like symptoms could be some signs and symptoms of rejection. Patients may also, in heart failure, need valve replacement. So there's many different types of valves. There's mechanical, heterograph, and homographic valves. And nursing care for patients that have had a valve replaced is very similar to a patient that's had coronary artery bypass grafting done. And we've talked about this in the past, so you can refer to your book for further information in this area. This slide just shows some different types of artificial heart valves that are used on patients. Other treatments for heart failure for patients, if medications don't work, patient may need cardio resynchronization therapy, sometimes called biventricular pacing. And with this one, both pacers are placed in both ventricles to contract simultaneously to resynchronize ventricular contractions. This will help to optimize left ventricular filling and increase cardiac output for that patient. We've already talked about ventricular assistive device, and we've already talked about continuous positive airway pressure, or CPAP machines. We talked about that in the sleep apnea lecture. Education for these clients includes monitoring signs and symptoms of heart failure, avoiding fatigue, and plan for activities. Try to eat healthy meals with sodium restrictions, take the prescribed medications, and make sure they're doing follow-up care and lifestyle accommodations. Nursing interventions for patients in congestive heart failure are to include also oxygenation, monitoring pulse ox. That patient's probably going to be most comfortable in a semi-Fowler's, and this will help increase cardiac output. Balancing rest and activity is important, and remember that these patients will have very careful head-to-toe assessments every shift to look for edema, shifts in I&O, the lungs filling up, development of liver failure, and all those different types of things. Skin care is important for these patients because, like we said earlier, edema is very common with them, which leads to increased risk for skin breakdown. Monitor for constipation due to the nausea, vomiting, and liver engorgement, and give medications and monitor for side effects. The caregiver is also under a lot of stress for those patients with congestive heart failure. The caregiver may feel very depressed, fatigued, overwhelmed by taking care of someone with a chronic illness, so trying to get them into a support group would be very important. This slide just talks about the differences between pulmonary edema and how that is different from heart failure. Usually pulmonary edema has more of an acute onset of symptoms. The patient becomes very short of breath, starts to have pink frothy sputum. The patient gets very hypoxic and restless. We'll have low O2 sats. You'll see changes on the chest x-ray in the lungs. The ABGs may be poor. And patient needs to be treated with morphine diuretics, dobutamine, which will increase the contractions of the heart, Natracor, and different types of bronchodilators. So nursing responses would be to include raising the head of the bed and trying to position that patient so that they would have the best cardiac expansion that they could. So please refer to your book for further information in this area. This is a couple of NCLEX questions that deal with congestive heart failure, and you'll find the answers of those in your speaker notes.